My name's Andrew Fishburn. I'm a Macmillan nurse consultant in head and neck cancer at Lancashire Teaching Hospitals NHS Trust. I think that shared decision making is really a partnership with patients. Our role as nurses, I think, is really to translate those really difficult to understand jargon terms from what we understand and use every day in our professional language into a language that patients can understand and process, and then make an informed decision about what their treatment may be. Sometimes shared decision making is really about allowing patients to arrive at a decision that may be contrary to what we believe is in their best interest. But if a patient's competent to make those decisions that we believe is in their are not in their best interest, then we have to support that decision making. And as long as we facilitated that role as a nurse, as a health professional, then I think we're perhaps doing our job well. When I had one particular patient who was unsure about what the treatment for the voice box cancer was, the patient had a locally advanced disease that was still treatable and potentially still curable. However, the treatment would have involved either chemoradiotherapy and keeping the voice box, or surgery to remove the voice box, followed by radiotherapy or chemoradiotherapy. And the initial decision of the patient was to leap towards what we call organ preservation, so keeping the voice box and going for the chance of having a treatment that would allow them to do that. However, when we explored that in greater detail so a patient could make a more informed decision, we talked about the potential prognosis with surgery followed by radiotherapy or chemoradiotherapy, or going for upfront radiotherapy stroke chemoradiotherapy. And the evidence suggests that it's a better prognosis in that particular patient's scenario to have the surgery first, and that allowed the patient to make a decision based on what was the most important thing, which was quantity of time ahead, giving herself the best chance of living a long life following this treatment. And bearing in mind that this patient was a single mother with 2 kids and she was young, the last thing that she wanted was not to be around for her children. And despite the horror of the thought of not having a voice box, when we talked about rehabilitation and communication, which incidentally was probably going to be better than a pre-treatment voice because she already had horrendous hoarseness of voice, and she was an extremely motivated woman, she came to the conclusion that actually the surgery up front was perhaps the best thing for her, because it would have given her the best chance of a long-term cure. Guided decision making is one of the things that perhaps I struggle with, and I'm guilty going down that road sometimes with patients, and it's a really difficult place to bring yourself back from sometimes, and the area around guided decision making, I think that can be one of the strengths of nursing and some of the conversations we have with patients, because it's about sharing that knowledge that we have with patients, and that may influence their decision making, but it's important that we share that knowledge in a very open and honest way, so that patients can arrive at the decision that's best for them. So for example, there's a perception out there when it comes to oral surgery for head and neck cancer that an easier option may be radiotherapy or chemoradiotherapy. And when you explore that perception with patients and give them the information around the effects of radiotherapy to the oral cavity and the challenges that that brings, that will often, in inverted commas, guide patients back towards surgery, because the perception that radiotherapy is a much easier option than surgery is erroneous. It's just not the case at all. And radiotherapy and chemoradiotherapy for the oral cavity is certainly in the observation I've made of patients going through that process, is certainly much more difficult than surgery. Surgery, you have your surgery and you get better every day afterwards. With radiotherapy, the effects are cumulative and last a long time afterwards to get over them before you begin to get better. And often guiding patients with that information can be interpreted as influencing them or guiding them, but at the end of the day, you support whatever decision that they make, whether or not we believe it's in their best interest or not. I think the first top tip I have is be honest with patients. The second top tip I have is it's really important to understand what a patient's level of understanding will be, their baseline. And thirdly, I think it's important to use patients as a teacher to you. So getting patients to, particularly when we're, for example, having difficult decisions to make, doing things like chunk and check, which I know is a Breaking Bad News model, but using chunk and check so you can check patients' understanding of where they're up to at that point and they've made sense of that information, and then getting them to teach you what they interpret that information to be, can be a really good way of helping them to make sense of this myriad of difficult, complex information that allows them to come to the conclusion of a decision that's right for them.